Good morning, good afternoon, and good evening, everyone, wherever in the world you may be joining us from today. My name is Francesco Del Carpio, and I am the CFL York Operations Coordinator. I would like to officially open the fifth session of our 2025 sessions in our Emergency Management in Hospitals and Healthcare Speaker Series, presented in partnership with the Thunder Bay Regional Health Sciences Center. I would like to begin today with a land acknowledgement. We acknowledge and recognize that many Indigenous nations have longstanding relationships with the territory upon which our campuses are located that precede the establishment of York University. The area is known as Tikaranto and has been caretaken by the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It is now home to many First Nation, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation. The territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. As this is an online event, our participants may be joining from various locations, so I strongly encourage you to learn about the traditional land upon which you are located. With this, I welcome our moderator, our speaker, and our participants from around the world. Welcome to our webinar. It is now my great pleasure to introduce Misha Richard as today's moderator and our partner, or our lead organizer and partner from Thunder Bay Regional Health Science Center. So as I mentioned, Misha Richard is the Emergency Preparedness Lead at Thunder Bay Regional Health Science Center and facilitator for this CFL York and Thunder Bay Regional Health Sciences Center collaborative series, and will be moderating today's session. Misha, thank you very much for moderating today's session and for your ongoing help in putting together this series. For the sake of time, I will be sharing Misha's full bio in the chat so that everybody can read it there. But for now, Misha, thank you again. The floor is yours.
Lovely. Hello, everybody, and thank you for joining us. Thank you for the introduction, Francesco. I get to introduce our speaker today, who will get the full bio. Without further ado, welcome to Shannan Saunders. Shannan is an accomplished emergency management professional with over 15 years of experience in crisis, emergency, and continuity management. She currently serves as the Director of Emergency Preparedness and Support Services at Collingwood General and Marine Hospital, a position she assumed in 2024. Prior to her current role, Shannan held a position of Site Director for Emergency Management at Mount Sinai Morningside Hospital in New York City. This is where she oversaw all emergency preparedness and response activities during the peak of the COVID-19 pandemic. Her extensive background includes roles such as Manager of Emergency Management at Durham College and Senior Policy Advisor for Business Continuity and Emergency Management with the Ministry of the Attorney General in Ontario. She holds a Master of Arts in Disaster and Emergency Management and is currently pursuing a Doctor of Business Administration. So before I give the microphone to Shannan, I'll do my quick reminder to everybody that's joining us today. If you haven't been with us before, thank you for attending, and thank you to all those returning attendees. The chat is open for you to communicate amongst yourselves, but if you have any questions that you would like Shannan to address, please use the Q&A function. I'll be monitoring our Q&A box throughout the presentation. So Shannan, thank you so much for joining. Looking forward to hearing your topic today. The mic is yours. The mic is yours if we can unmute you.
Yeah, the mic is mine. And I just share my slides so everybody can see my slides. Fantastic. Thank you so much for that wonderful introduction. Today, we're going to talk about building resilience in healthcare. And hopefully, I'm going to smash some of the myths in what resilience is and what it's meant to do, and engage in some conversation and dialogue. So please do put some questions in the chat so that we can make this a useful talk. It's not letting me change pages. Hang on. So I just want to very quickly, I know the objectives were put into the invitation, so I just want to quickly remind everybody that we have 3 objectives. Hopefully by the end, keep me honest, that we've met all 3 of these objectives. So let's talk about understanding what resilience is and what healthcare resilience is. And the first thing I want to say is resilience has really become a term that is marketable. It's commercial. We've overdone it a little bit with it's business continuity, it's disaster recovery. Everybody's kind of tried to grab a piece of resilience and make it their own. And it is true. When we talk about emergency management, that is resilience. When we talk about business continuity, that is resilience. But resilience, and when we talk about disaster recovery, I don't want to leave my IT friends out. When we talk about disaster recovery, we are talking about resilience. But what we're really talking about is components and strategies that we use to help build resilience. And there are more strategies than that as well. So I just want to point, that's what we're going to talk about for the next hour. So before we get there, though, we're going to define resilience so that we're all on the same page. The fun thing about researching resilience, which is the topic of my dissertation, resilience in healthcare, the fun thing about researching it is every single paper that I have ever found on the topic of organizational resilience, healthcare resilience, even resilience in science, in about the third or fourth or fifth line, there's always a statement that says we really don't agree on what the definition of resilience is. So it's always fun to search a term that we're arguing about the definition, or we're combining definitions on a regular basis. And that's exactly what I've done here. So I'm going to draw you back to ecology and the study of plants that cannot pick up root and go somewhere else when they're exposed to changes in the environmental conditions. So things like an early frost, things like a forest fire, a plant is either going to survive or it's not going to survive. And the resilience really is their ability and capacity to tolerate the disturbance. And this is where we kind of get the term bounce back. So if we go back that far, this is really where the modern day usage and operationalization of the term resilience comes from. Social science took that and said, well, if plants and animals can be resilient because of their ability to tolerate disturbances, so can people and systems. So we see more words here like reset, absorb, adapt, transform. We're starting to look at things that not only help us get through those environmental changes, but it also helps support us to do better coming out of those changes. And I want to point that out because social sciences really does a good job of saying it's not just about bouncing back and getting back to what is quote unquote normal, because that's another term we have a hard time defining, but we can also, what can we do to be better? So the next time there's a disturbance in the environment, we're more prepared for it and we're more resilient to those changes. And then medicine kind of took it over and said there's a capability for a suitable response to stress. This is looking more at the individual and looking more at some of the physical symptoms that we have when we are or are not resilient. There are a large number of studies, both from medicine and psychology, that look at the resilience of children, particularly in environments that are not considered sustainable. So a domestic violence situation, abuse or neglect situations. Why are some children more resilient, some children less resilient? It's a little bit harder to study the adults in resiliency. We do it, and there's some good new psychology research on it. But we talk about our ability to be flexible. We talk about our ability to adjust. And it's not just about picking up and moving away from what makes us uncomfortable in the environment. And then psychology kind of splits into two pieces. And one of the newer pieces of psychology that's looking at resilience is the industrial organizational psychology realm. So this is looking at organizations, how we build teams, how we build systems within the organization to be able to be effective. So we're meeting the business goals. And then IO psychology is also looking now at resilience and how do we go beyond just meeting business goals, but when things change, our financial situation changes, there's a new competitor in the marketplace, those sorts of things, that the organization has a behavioral flexibility as a group and as individuals to be able to go forward. And one of the things industrial organizational psychology really looks at is the mental, emotional, and behavioral health of the team members. So it's not just looking at the organization, but we're looking at the individual from a medicine and purist psychology perspective, and we're looking at it again from the team perspective. So we'll talk a little bit about what that means for organizational psychology development in just a second. And then in healthcare, we needed to have a definition, and there are a number of definitions with the new research that's come out in the past years post-COVID. This is the one that I like, so this is the one that we're going to be using for the conversation today. And it's not just the ability to bounce back from a normal state, but it's the ability for us to adapt, learn, and grow stronger, which I think is integral to some of the strategies we put in place. So if you're an emergency manager, you know about adapt, learning, and growing stronger. The whole point of business continuity strategies is to be able to do that as well. And when we look at it from a business and strategic oversight and governance perspective, we're looking at those things as well, which is going to become important in the conversation in a second. So that's the definition we're going to use going forward. So our journey in healthcare resilience actually starts in the community. It doesn't start inside the hospital. We'll get to the hospital in a second, but it starts within the community. And the city resilience framework that you see in the nice circle on the left side, I'm going to talk about in depth in a second, but I also wanted to show you some of the spaghetti diagram that when we started converting the last rendition, this is the third rendition of the city resilience framework. When we started talking about what each of these kind of posts or spokes in that circle mean, it really becomes a complex spaghetti diagram. So I don't want people to think that everything has, equal footing in this model. It's just a pretty model to put on paper. We can talk about the complexities of how healthcare delves into economy and society, how our infrastructure and environment affects healthcare, how our local governance and planning really impacts our people health in the community, and the impact of people health and how it impacts on us. So let's look at this a little bit more closely. Health and well-being is a quarter of the circle. We have impact. We have direct impact from the healthcare perspective, but if you look closer at the circle, it's not just our ability to provide health and medicine when people get sick or when people get injured. When we also look at healthcare here, I also want to point out that we play a significant role in the local governance and planning for a community. You cannot have a community if you don't have access to healthcare. And we saw that, I'm going back a little bit with this one, but we saw that in the Fort McMurray fires in Alberta a number of years ago. We evacuated an entire community, and before we could return that community to their home, we needed to make sure we had healthcare. And it's not just the access to the hospital. The hospital is going to get overwhelmed if all we do is open their doors. We need primary health physicians. We need urgent care centers. We need pharmacies. We need labs. We need alternative medicine providers to be in the community in order to really have a resilient community. So our journey starts with working with our community leaders, with working within the economic and societal frameworks of the communities that we live and work in, and making sure that we are contributing positively to the health and well-being, as well as being a positive piece of critical infrastructure as a system, not just as a building. It's more than just our hospital, but as a system, we're critical healthcare to ensuring the well-being of the community. And remembering that our staff live in the community. So if a community is affected by a disaster, not only are we going to be affected with an increased number of patients, but our staff members, our team members, our physicians, our volunteers are going to be impacted as well. So we need to think about the other pieces of city resilience in order for us to be resilient as a piece of that. So that's kind of where we start. And then these two frameworks really look at organizational resilience from a practical perspective of strategy, structure, and culture, with people in the middle. If you don't have a strong team of people, you are not going to be a resilient organization. It doesn't matter what kind of organization you are. And it doesn't matter how technologically advanced and AI generated and robotic your organization is. You still have people at the center of organizational resilience, because machines are going to break down, things are going to change and need to be adjusted. We're going to need to do maintenance. And that's on the most technological and robotic lines for like car manufacturing and things like that. We can't do that as healthcare, right? We can't be that robotic So people become a really critical, important part of our resilience. And we have to consider and we have to worry about what individual resilience actually looks like in order to make sure that we have resilience in our healthcare system. So taking care of our team members, psychological wellness, making sure that people have the tools to do their job, reducing some of the frustrations that we have, building teams that work together collaboratively. All of these things that we do from a strategy development and business perspective lend to our being able to be resilient when something happens to disrupt the environment that we're in. So culture plays a big part of that. Strategy plays a big part of that. And then the structures of our teams, how we standardize work, how we make sure that employees understand the work, they're onboarded correctly, all of that sort of stuff becomes really super important. And then this other framework I'm not really going to go into, but these are some really interesting resilience factors. I think we think about a lot of them when we do things like business continuity and emergency management naturally. So it's making sure we're doing it with a purpose and making sure we're actually considering some of the factors that make the organization resilient, not just our ability to respond to an event, which is also important. But if we do resilience right, our need to respond to events actually goes down. So this is the organizational framework that we're working with. And then we draw it down to what a healthcare resilience model looks like. This is a relatively new model. There are a couple models out there that are gaining speed in different ways. I like this one because it really takes a look at a holistic. You need to have a societal participation and you need to communicate both inside your healthcare system and your facility and outside. So how many of us actually collaborate and talk to our primary care physicians who don't have privilege inside our hospital? And that's a big ask for a large city hospital or healthcare system because we have a lot of primary healthcare physicians. But at the same time, we never seem to have enough. And I've worked in a few different healthcare systems now. And the common denominator for resilience when we talk about societal participation and communication is this lack of connection between your primary care physician and what's going on in the hospital. And it really doesn't matter what model of healthcare we look at. That seems to be a common thread. And it's pulling us away from being able to be resilient as a healthcare system in order to serve our community. So that and the context in which we work become very important. And you'll notice the people in the center. I cannot talk about this enough. I could do a whole hour conversation on how we build teams to ensure that we have resilience within organizations. And there's a lot of great research out there I can send at the end of this. If you're looking for specific research, I can send you research there. So if you are an emergency manager or business continuity or disaster recovery, you're noticing a few things on this list, kind of the spokes in the middle of the wheel that we don't normally think about, or we don't spend a lot of time thinking about. Things like sustainability. Our ability to be environmentally sustainable plays a huge role in our hospital's ability to be resilient to changes in the environment. We're starting to look at sustainability in healthcare on a global scale. And by the way, if we were a country, if healthcare, global healthcare was a country, we'd be the fourth worst country for environmental sustainability. We're dirty and we're messy and we waste a lot. And that doesn't help us be resilient. So one of the things that needs to be a focus and a change in how we fundamentally operate day to day is our consideration for environmental sustainability. Now, the good news is that a lot of people have eyes on sustainability. So we have a lot of help and we have a lot of support. So for example, if you're in Ontario, and I'm just going to use the Ontario example, one of our major group buyers, Mohawk MedBuy, actually has a large team working specifically on sustainable supply chains and sustainable purchasing. And I know we take that from European countries. I know there's a lot of European countries who within their healthcare infrastructure and within their government funding model are looking at the sustainability piece. And that's super important as well. And then finance is another piece that we don't often, from an emergency management, business continuity, or disaster recovery, we know things cost money. We know response costs money. We know prevention and preparedness saves money. But looking at it from the lens of anything can change our finances at any given point in time. If you're in a private sector system of healthcare, a new healthcare leader like Mark Cuban can walk onto the scene in the United States and disrupt everything. And now everybody has to think about how they're doing pharmaceuticals through their insurance company. It's a huge ripple through the insurance industry and how we're doing pharmaceuticals because one guy with a little bit of money has decided to disrupt everything. It changes how we fundamentally do things within the hospital and healthcare. And from the Canadian system model, and I think I can speak for all provinces on this, what happens if the government, one day the provincial government devalues healthcare and says, we don't care, we're going to spend money over here instead? It happens every 4 years with the changes in government, right? Every time there's a major change in government, there's a major shift in the funding model. And it puts us into a position where we have to think about finances as an emergency on a regular basis. We have to think about cuts. We have to think about doing more with less, which is the worst phrase in the world, but very popular in public sector. So we need to think about finance. We need to think about our governance. Who are our leaders? If our leaders are government officials, there's a different way we have to set up to be resilient because we know those government officials are not going to be long term. Our government officials are here, gone. We switch, we change parties, we move alliances. It brings challenges to being resilient as a healthcare system. And we saw that across the world during COVID. There weren't a lot of governance systems for healthcare globally that were resilient enough to jump up and manage COVID. Now we did, and we built that resilience, kind of building the plane as we're flying it, so to speak. But being able to build strong governance models and strong partnership models is really super important. The actual medicine we provide is another interesting one that we don't think about. But things like the use of nitrous oxide, things like the use of insulin inhalers, that kind of speak into the sustainability piece. And then our dependence on certain tools and resources. A lot of people are becoming dependent on things like the Da Vinci surgical tool. It's a robotic, does certain surgeries in a very short period of time. We can't exactly move that device out of the OR if it stops working, or if we have a massive power failure in conjunction with a mass casualty incident. So we need to think about how our medicine stays resilient and how we're staying on top of the technology. I love the use of the technology. I think the Da Vinci device is probably one of the best things ever invented for a surgical suite, probably with more and better technology to come. But we have to think about being resilient, and what does that mean for losing a surgical suite that we cannot use in the same way if we don't have access to the technology? If a cyber attack hits the company and the devices all shut down, if there's a massive power outage, all of those things that might be able to affect those. So our ability to do medicine is the same thing. I already kind of talked about resources and supply chain and the need to have the access to the supply chain and a sustainable supply chain to help us be resilient. And then actually how we set up providing service. So we have a public health approach to this and we have a medical approach to this. And it's really super important that we link those two together. So the connection between what's happening out in the community from a public health approach, things like uptick in measles, for example, our flu season, simple things, to more complex things like the next pandemic or novel disease that's going to come. And we need to connect that with our medical approach. It's reducing wait times. It's making sure we have patient flow through our hospital. It's making sure that patients have access to healthcare once they leave our hospital. It's making sure that patients have access to meals, right? We put somebody on a soft food diet and send them home and say, go get yourself a blender. But we don't give them the recipes, and we don't give them the tools, and we don't give them the ability to actually transition from hospital to home, because our job is done when they walk out the door. So we need to do that reconnection from primary care before they get to us in the hospital, and then back out the door on the other side, back into the community, and be able to do that. So I really like this model. I think it touches on a lot of things, and I probably could talk a lot more about a lot of it, but this really is the nuts and bolts of this presentation. And if this is what you take out of the presentation, we've done a good job today for the piece there. So let's talk about some strategies for resilience and bring it back to the things that we actually do. So some of this you might see as familiar, some of this you might be doing, but how often do you connect as your crisis management department or your emergency management department? How often do you connect with your human resources department? And how often do you look at the built structures of the teams and the standard work that you do as an aspect of resilience? Right? We talk about it from the perspective of bringing home or retention. We talk about staffing numbers. We talk about vacancy numbers, but we don't actually talk about providing the teams that we built with good work that they're going to be able to do in certain levels of environmental changes. There are levels of environmental changes that are always going to pop up and we're not going to be able to deal with. But we can prevent a lot of that by looping in some of these other departments. Making sure we're financially viable. I think I talked about that one a lot on the last slide. Making sure that we're compliant legally and financially. If we're signing contracts for things, making sure that our contracts are also resilient and our vendors are also resilient, and that we're compliant with things. The biggest cost after an emergency is finding out that we were grandfathered into something or we're not compliant with something, and being able to go from there costs us a lot of money in recovery. So making sure that we're continuously auditing ourselves and making sure that we're compliant. And hopefully, particularly if you work in a government-centered healthcare system, that you have the support of the government for these audits and for this compliance. And we're not being complacent with things like changing elevator regulations, changing nuclear medicine regulations, and that sort of stuff. We do have to have a strong business continuity or continuity of operations program to be able to make this work. This is where you're going to find the strategies in all of these other places that are actually going to do the most good. It's from the team up. So it's from the local, what's happening on the floor, what's happening in the unit, how the nurses are feeling, how the cleaners are feeling, how the dietary staff are feeling, what kinds of patients are coming in the door. All of those things we can capture in a good continuity program, and we can build our resilience strategies around it. And I'll say the same thing for risk management. So continuity and risk management have to work very closely together to be able to connect those dots and put those dots and pieces together. Then we have to look at our critical environments, and I'll tell a quick story about a fictional hospital who had a power outage. And what they didn't realize in the power outage, because all the red plugs worked, so all of the critical patient equipment worked, but what they didn't realize in this power outage was that there were other critical environments, like the lab, that overheated because we don't have the air chillers for that particular area on backup power. So when a lab overheats, some of the reagents stop working. So now we've lost reagents. Some of that stuff is hard to get. It takes a couple weeks to bring in. So it slows us down. Now we can't do labs. IT infrastructure is the same. We keep expanding our technology. What we don't see on the outside that always shocks me is on the back end of that, our ICT, our infrastructure technology has to go in, and now we need more server rooms. So we're putting servers in closets, and the question becomes, yeah, sure, we can put a red plug in there, but those rooms overheat really quickly when they don't have active air circulation and active air conditioning. So being able to connect our business continuity with our IT infrastructure, being able to look at some of those critical environments, and seeing what's in there. We had a flood at my last hospital. One of the OR storage rooms flooded. And what we didn't realize was we had all of the critical systems for our OR in that one closet. So putting everything in the same place, we lost a lot of things and it delayed our recovery. Had we done a proper business continuity assessment of that area, we probably would have caught that and made some adjustments, and been able to jump forward from that. Infrastructure security is one of those areas as well that we talk about resilience a lot and the ability to bounce back a lot. I don't want to bounce back from an infrastructure or information security issue, a cyber attack. I don't want to be able to bounce ourselves back to normal. I want to be able to patch that attack. However that attacker got in or potentially could have got in for our near misses, I want to be able to catch those things. And then that ties in with the incident response. So we have our crisis management and our incident response capabilities. This is everything from our color-coded hazards, being able to do a good hazard assessment, lining that up with the risk management and risk assessment, being able to understand that when we're responding to an incident, where does our IPAC or where does our IPAC fit into all of this? So from a risk management perspective, our infection prevention and control is really super important. From an incident response, we think we're in an emergency, so maybe we don't have to think so clearly about it, but we're not resilient when we skip those steps. So in our incident response, we have to think about all of these other little things that kind of carry on. And the one thing we probably have the least direct impact on and the most indirect impact on is our organizational behavior. This is the industrial organizational psychology, how we build our teams, how we put things together, how we come together as an organization, because it's those people being able to come together to solve extraordinary problems that are going to help us be resilient when we do see a change to the environment. So let's talk about the culture of resilience. And I love this. I stole this from Blackpool Council. It talks a lot about personal perseverance, but I think this particular model is really super easy to translate into that organizational culture, into that organizational behavior piece. And it's understanding the psychological wellness of your staff is a bunch of things. And being able to commit to it and kind of understanding those noble truths. We are going to have emergencies. They are going to suck. And we have to accept that as a truth. The environment around us is going to change. Funding is going to change. Access to equipment is going to change. Our buildings are going to get older. There's a lot of things we can't control in healthcare. And we need to understand that we need to be flexible to our environment. And we need to be able to commit and enlist other people to understanding. We kind of need to have these colorful pieces on the top. And this is really where medicine and psychology agree on resilience very strongly. And we put together, once you have your basics, I can get to work, I can feed myself, I can feed my family, all of those Maslow's hierarchy of needs, right up to self-actualization. Then I can start working on belonging, learning, coping, and core self. And it's our job as organizational leaders. And ironically, it's really our job as emergency or crisis managers to start building this comfort and start building this understanding and confidence that, yeah, disasters are going to happen. Weird things are going to happen. And it's not going to happen in the way you think it's going to happen. We have an ice storm and the power goes off, the generator comes on. But when we turn the power back on, all of the insulators on the poles owned by the power company start frying because the ice is jammed in there and it's caused an arcing. I can't control that. I can't control how that happens. But what I can control is that the staff, the partners, the providers, the volunteers that are inside the organization when it happens are confident and comfortable enough to make a decision to forward us in the right direction towards resilience. And that's really our ability. That's really the core of what we need to do in disasters and emergencies to make sure that that we're resilient as an organization. And there's all kinds of things in here we can play with and we can engage with. And some of it may or may not work for your organization, which is why I kind of like that this has a ton of options and availabilities and conversations to kind of go forward from there. So this is another slide. So the healthcare resilience circle is a really good slide, really important slide. And then this one as well. And Blackpool Council, if you Google their resilience, they have a lot of supports like, how do I get to a place where I can be brave and I can help my staff be brave? Where do I get to a place where, we're taking care of the core needs, the basic needs of our team members? Because we don't really have money as organizations to make sure that everybody has housing and shelter. So where are the resources and how do we help and support that? And Blackpool Council has some great ideas and suggestions to be able to do that. And the cool thing about this is if we start doing this with our staff and we start doing this with our team members and we start reaching out to the providers that are in the community, our physiotherapists, our occupational therapists, our psychiatrists and psychologists and primary care physicians, and we reach out beyond the hospital with this model of we need to make sure people are comfortable when crisis happens and they're confident that if they make a decision, it's going to put us in a better place. That's going to spread like wildfire into the community, and Blackpool Council was able to do that. So it's a really interesting case study, as well as a fun infographic. So this is just a few references that I pulled out that can be shared. I know some of them showed up as links and not the actual URLs. But if you work with CFAL, I'll get you any of the references, and there's more that I can share if you have any kind of specific information. So that's what I have out the hop. If anybody has any questions, I haven't really been monitoring the chat. I know you have, Misha. If there's any questions or concerns or you want to challenge anything, I'm happy to hear it now.
Okay, awesome. I appreciate when folks can focus on a few key slides to try and get the messages out, especially since these sessions are recorded, so folks can go back and refer to the diagrams. Again, as Shannan mentioned, these resources we can connect you with through the CFAL. I wanted to touch on something. So Shannan, before we get into like all the gratitude and stuff, we have a lot of time to still be able to address questions. I didn't see any come through the Q&A. There was some discussion back and forth as far as just folks connecting in the chat. And this made me think of the dreaded A word in this case, which is accreditation. So when you were discussing this and talking about our compliance, when it comes to like legal and regulatory, for many of us, there's also those connections as far as what are the best practices and our expectations related to accreditation. And so when you're talking about people being at the center of the organization, all I could think of was in the accreditation standards that we're working with, at least in Canada, and I can't comment on how some of our peers outside of Canada, what you're trying to work with. But a big push in this latest was about personal preparedness and, trying to understand what the community risks and needs were. And those were things that were never a part of the consideration and accreditation standards previously. So that was a long-winded way to say, Shannan, what do you think about what you're saying and how this ties back to some of these expectations that we now have in healthcare organizations that are laid out and our updated accreditation standards?
So every health system, I believe, and somebody keep me honest, if you're living and working in a country that doesn't have a regulated healthcare industry, let me know, because I'd like to study it, because I think that would be fascinating. But I think we all have some kind of regulation in healthcare. It's very commonly an overly regulated, in my mind, thing. I can speak very specifically and very intimately to American regulation through Joint Commission and Center for Medicare and Medicaid, and compare that to Accreditation Canada and some of the accreditation standards that we have. And then the other kind of piece that I want to point out before I dive deeper into what I think is we also have to think about other standards. So particularly, globally we have ISO standards. NFPA standards are very common in many countries around the world, not just Canada and the United States. So being resilient and being able to adjust and adapt to changing environmental situations isn't just about the accreditation standards for how we practice. It's also how we build our buildings and how we maintain our buildings. So, I talk about things like, elevator standards. We have to have a working elevator in order to do OR. You'll never convince me of otherwise. Because if something goes sideways or if something goes bad or if a trauma comes in, I have no way of getting them from the first floor to the third floor or the fifth floor or the eighth floor. And I'm not convinced putting the OR on the ground floor, particularly in flood prone areas, is a good idea. So there's a lot of thinking about building standards and stuff like that also has to go into it. I am not the expert in building standards. There are experts out there. Go find the expert in your community and talk about how we can build more resilient hospitals and buildings. And it's interesting because it goes back to the old idea of we're building an H. Building hospitals into an H is actually a resilience thing. That makes the structure more resilient to things like tsunami waves, tornadoes, hurricanes, that sort of thing. So don't discount some of those other standards. But our practice standards, our Joint Commission standards, our Accreditation Canada standards, we are seeing an increase in things like, I think the last major revision for Accreditation Canada you have to involve your PFAC, which is your patient and family committees. You have to involve the community in what you're doing. I don't think there's an emergency management standard in the standard. I don't think there's a component of the emergency management standard that doesn't have community participation. Talk to your community, connect with your community emergency management, connect with the physicians in your community, which we don't do well. I am going to say, even in the standard, we don't talk a lot about those connections, and we probably should. You are going to see in both Joint Commission and in Accreditation Canada, you are going to see environmental sustainability. That's coming to both standards. So I think if you're working within those standards and if you're around the world doing Joint Commission International, you're already doing environmental sustainability in your Joint Commission International standard. Because we need to know that our facilities as critical infrastructure are going to be protected from things like wildfires, hurricanes, tornadoes, whatever else you want to bring up in the millions of hazards. I think we're up to 86 hazards in Ontario now. So whatever it is, we have to be, I couldn't resist putting that in. Whatever it is, we have to be prepared for it. And these accreditation standards, I think, are going to help us. And the personal preparedness piece and things like that. Like, if people aren't comfortable, they're going to leave your organization 1000%. And we saw that in Katrina, and I hate to go back that far because that's an old lesson learned that we should have learned. But we saw that people went home to care of their families. When I started with the Attorney General, there was a big tornado in a town in Ontario that impacted the entire town. How can I expect a judge and a lawyer to show up at court the next day, let alone a defendant, when their house has been destroyed? So if we're not taking care of the people and the people aren't comfortable and confident, they're walking away from you. And that was the secondary disaster in COVID, right? We lost probably half our staff in most of our hospitals around the world, because they couldn't do it anymore and they walked away. That's my long-winded answer to your long-winded question.
Perfect. This is why we're friends. I was also thinking too, I was just going to make a comment because when you were listing all of these different kind of components, it was making me wonder about some of the challenges between a smaller organization and a larger organization. So for a smaller organization, you might say, well, there aren't as many resources, but perhaps people are wearing multiple hats. So when you're saying, there's business continuity, and then you've got incident response, and, you're listing all those different bubbles. In a smaller group, it might only be 3 people that represent all of those bubbles, which is a pro and a con.
Right.
So I wanted to just kind of note that obviously we recognize there's very different attendees on this call that might be representing a wide array of, kind of size and structure of different hospitals and healthcare networks. But folks were asking in here as well about some strategies kind of in the Q&A.
Yeah.
As far as, we can't do that. It's going to cost too much. Like, how do you get these business continuity conversations started? They were referencing your example of having, a multitude of critical infrastructure located in the same closet. So any thoughts on kind of that? Because I was thinking as far as those challenges between the different organizational sizes, but obviously questions in the chat are, wait, how do we even get this conversation started regardless of organizational size and structure?
Fair. So, I always like telling the story of, when you see communities post disaster. So, hurricane hits Prince Edward Island, which is a small province in the eastern part of Canada, 180,000 people in the entire province, and it's an island. So they're very easily cut off from everything. And a hurricane, they're in Hurricane Pass. They get a number of hurricanes every year. And I remember hearing about Hurricane Juan, which happened probably 15, 20 years ago now. What happens in a community like that is people get out with their chainsaws. People go to their neighbors. The one person that still has power and can cook is cooking for the entire neighborhood. And then you come to Toronto, which is a city of, what are we up to, 7 or 8 million people now, in the GTA, not just Toronto, but you come to the GTA and we have an ice storm in 2013. And people don't understand, and it's winter and it's cold outside, and people don't understand how alternate refrigeration works, right? Where I grew up in the middle of nowhere, and you put the milk in the car and hope it doesn't freeze, right? Where in a bigger city, we've lost some of the capacity. So I work in a small community. I wouldn't call it a rural hospital, but we're a moderate sized hospital with in a community of about 38,000 people. So people think that's small. I think it's perfect. We really look to, it's not a big formal conversation. I meet the fire chief at the grocery store. Hey, what do you think about this? Like, we hold up the line we've done this a couple of times now, where we hold up the line at the grocery store talking about what may or may not happen and come up. And we have that community spirit that I think the bigger cities don't have. So when you talk about balance, it's harder to make the relationships, I think, in the bigger cities sometimes, particularly when I'm talking about your primary care physicians, right? I know every primary care physician in Collingwood. So to have a conversation with them and say, hey, can we help you with your business continuity? What are you going to do if your clinic has to close? And how can we help you? Because we're all in this together. I don't think if I was working at a major city hospital in Vancouver, I would have that same opportunity because I wouldn't know. So we'd have to do something a little bit more formal. Somebody asked the question about where do you start? And continuity of business continuity versus continuity of operations. That's a great question. They're the same thing. I don't care what anybody says. It's like saying resilience is business continuity. Sure, business continuity is a strategy in resilience, but it's the capture and marketability of the terms. I think they're the same. I will argue that as the day is long, because I think they're the same. They've got the same purpose. So we might adjust the tools a little bit. And to that, I say, grab all the tools you can. Because starting with this is awkward, particularly with the frontline clinical staff. They're not a business. They're never going to think of themselves as a business. So when you bring them a business proposition, it's like minds blown in a lot of cases. So it's trying to adjust I don't call it a business impact analysis. I call it an operations impact analysis because really we're looking at what's going to impact your operations and what strategies can we put in place. And you read the culture of the room of the organization. I'm small and it was set as a strategic priority before I got here. So I'm small and I'm lucky, because people just do it because they understand that it's on our strategic priority list. How to get it on your strategic priority list? Every disaster that you have, every disaster that a neighboring community has, follow Misha on LinkedIn because she posts a lot of them, and I forward them and I say, what would happen if this happened to us? And I'm not going to have a volcano erupt in my backyard, so maybe that's not a good example. But the impacts of the volcano erupting and turning off the power in a hospital or clogging up the air intake, I have that problem every time the helicopter lands. Every time an air ambulance lands, it sucks all the fumes from the air ambulance into my hospital because we're so small and compact. So I can take the lessons from everybody else and use it as a policy window to kind of push it on. Well, what if it happened here? I do a good job of the other thing I do is I'm okay with a little bit of fear. I learned that from the fire department, and babies are going to burn in their beds. I'm okay with a little bit of fear. So things like we just had a giant geomagnetic storm. I sent an article. You can't argue with academics. I sent an article to my chief medical officer, chief of staff, and my CEO, and I said, this is what's going to happen if this impacts communications infrastructure. And we're going to have all sorts of problems across the hospital with our ability to do things and call people in and stuff. So a little bit of fear, and it's a very slow, painful culture change. But nicking away at it and educating. I don't call it fear. I call it educating because that's what we're doing. We're educating and that sort of stuff. So that's that question. What else do we have in here, Misha?
Yeah, well, I mean, obviously I appreciate the shout out. As Shannan said, that I feel like that's a good opportunity for discussion is don't let somebody else's misfortune get away as a learning opportunity for yourselves. And sometimes things happen within your geographical area, which allows you to tie into that kind of maintaining of relationships and so on. I can comment that a hospital kind of within our broader network here in Northern Ontario did have a fire recently. We had communications back and forth with them. It was a great internal discussion to have as well at our organization. So, highlighting those things. So before they actually take place at your organization, what did somebody else learn from their experience? All starts with a conversation every time. There was a question here, especially that might pique the academic side of you, Shannan, which was asking about what is the literature tell us about the common reasons for kind of the denial in the need to address resilience or kind of the lack of interest. And this one is close to my heart, the lack of interest in addressing after action review recommendations. So it's one thing for us to say we're going to make a report because maybe it's for compliance or a legal reason, but then we don't do anything to actually address that. So what are your thoughts on that?
I'm going to start this by reminding everybody that I'm here as an individual and not a representative of my organization. Because I think, and I'm really lucky. I am super lucky that I work for an organization that gets it. They understand it. But I also look around, particularly the Ontario landscape. It's more entrenched in the regulation in the United States, so you don't see it as much there. But coming back to Ontario this past year, the weight that hospitals and healthcare systems put on some of this work is in some cases non-existent and extremely frustrating. We'll do what we have to do to get through accreditation, which, by the way, I should say, when we talk about accreditation and regulatory and compliance issues, right through governance and finance, like our compliance with an ability to do a end of year financial report and things like that. Those are the bare minimum standards of what we should be doing. So we should be building kind of beyond that. So it frustrates me to no end when I see organizations downplay or misuse and misinterpret some of these rules. And that could be an IT cybersecurity disaster recovery role. It's okay, it'll never happen to us, or we're paying somebody else to do it. That could be, sharing, and I see this a lot in emergency management, not just in healthcare, is I'll share my plan so that you can see, so you can create your own plan. And I'll gather plans from 5 or 6 or 8 different hospitals if I'm doing something new or I'm doing a significant update. But what you tend to see is they'll take my continuity plan, put their name on it, and put it on a shelf. And because it probably will work because we do the same things, but it doesn't really it doesn't really work when when it actually happens. And I'm going to use a term that a friend of mine coined is I'm a pracademic. So it's about how we can apply these things. and how we can practically take this. So I know, yeah, what does the literature say? The literature from an industrial organizational psychology perspective says don't do it. Says you need to elevate teams and you need to build the structure, and the structure will help you build the culture. So for us, practically, that means kind of a build it and they will come thing, and you might have to fight it. And a great example is we're doing code of the month 10-minute drills, and we're giving our staff, our managers, opportunity. You can do your own drill, and there's a QR code at the end of it, and I'm not above bribing, so you can win a prize if you fill out the QR code. And you're not going to be successful in answering the question, the QR code, if you didn't participate in the drill. But your manager can do the thing, and we get 2, maybe 3 departments doing it every month. We have 30 departments, 35 departments. So it's slow and it's painful in a practical perspective. The literature is very black and white. It says do it. And it gives a lot of opportunity to, like, there's different ways you can do it, and there's different kind of theories in how to create the structure that you need in the organization. I can't remember the name of the book. There's a book that I'll send it to Misha, and we can share it with anybody that wants to see it. But it's about influence without authority. So if I'm an emergency management coordinator, which by the way is the worst place to put an emergency manager in your organization, they need to be manager or above, and I'm really arguing director and above with clear access to the C-suite, particularly in a structurally, private with a CEO, a C-suite, CEO, board of directors. They need to have that access, and they can't do it as a coordinator. But if I'm a coordinator in emergency management, or I'm a coordinator in business continuity, I have to lead up more than I lead down. It's not the frontline staff. They get it. I have to lead up, and I have to spend a lot of time leading up. And there is a really good book on that. And I just can't remember the title of it. I can see the cover page. I just can't remember the title. So stuff like that. I'm more delve into the practical aspects of the how more than the theory aspects, just because I want to be able to apply it in my organization. But there is a lot of good theory out there.
I recognize that we only have a couple of minutes left, so I'm glad we did end up having time to address a few of the questions. I know kind of a last one that just got thrown into kind of the overarching chat was just chatting about, how to lead when you're not in charge. But I think there are a lot of strategies to take on that front where you don't necessarily have authority in order to still be a people leader. And we always try to say that, like, you're trying to find different champions on the front line. Sometimes easier said than done, but there are people that have that sense of care. There are people that others look to, and I think in one of your infographics, Shannan, one of the elements that got listed was talking about engaging mentors. And I view those as being those people leaders that are within your organization. They already exist. It isn't just us and our role in emergency management or business continuity in the organization. We're only one person. Some organizations are lucky to have a few people picking away on this front. But just when folks are saying, how can you lead when you're not actually in charge, is I think kind of getting that buy-in from various levels helps you have the weight to push some of those decisions or changes forward that you need, that you wouldn't have the authority to get through just on your own.
Yeah.
Final thoughts, Shannan, like as we're wrapping up here.
Yeah, it is. I love this. Inflate and inspire as a new emergency management motto. I love it. I think the one thing we have to be, I'll go back to kind of what I said on the very first slide, is the one thing we have to be very cautious of is falling into the pitfall of marketing resilience as I'm resilient because I have business continuity, or I'm resilient because I have emergency management, or it is so many little things that we have to think about holistically around the organization, and we have to challenge our leaders to think about as well. And I've worked in some organizations that I'm never going to convince somebody that we need to be more resilient, because they're just trying to keep their head above water. And I know we do a lot of that in healthcare. And I've worked in some organizations like my current organization where we get it. I mean, we're trying. We're not always going to get it right, but we're trying. We're giving it a good hard go. But to be able to kind of piece those pieces together is really super important. And think beyond the emergency response and think about how can I be more sustainable? How am I providing medicine and how can I do it differently if I have to? And outside the doors of the hospital is really the other thing, thinking outside that space. So those are kind of the key. That circle is really the key.
Shannan said it at the beginning, the circle. Thank you again to everybody who's attended. This session is recorded, so no, we don't circulate the slides. You can go back and see them as soon as we get that recording up on CFAL's YouTube channel, and then you can ogle all of those charts that Shannan was sharing, all those infographics, and hopefully be able to bring some of that information to your own teams and your own organizations. Shannan, I really appreciate you joining us. I know in the past, for anybody that wasn't aware, Shannan did participate on a panel about mass notification systems in hospitals, and you can check that recording on our YouTube as well. And so she was back to give us a dedicated solo presentation about, you know, building resilience in healthcare. And I think there's a lot of really great takeaways, and it's laid out in a way that is very easy to understand with all of those references to go back to. So thank you again so much for being a speaker with us today, Shannan. If anybody has additional questions for Shannan, Francesco has thrown his email in the chat, so please outreach. With that, I'll flip it over to Francesco to sign us off.
Thank you so much, Misha. Yeah, just quickly, I would just like to echo my thanks to Shannan. That was a great presentation. Thank you so much. And there was a great discussion afterwards as well. So thank you to everybody in the audience for participating and joining us today and asking questions. I also saw great conversation happening in the chat, building community for some people who are moving into the space here of emergency management in hospitals. So that's always fantastic to see. I'm always happy when people come together through the series that we do. And of course, thank you, Misha, for moderating today and for helping us put together this entire series and over the past 3 years. So thank you so much for your help with all of this and your partnership on this. And yeah, as mentioned, I've shared our social media for all of CFAL York accounts in the chat. I've also shared my email. So if anybody has any questions, please send them to me and I'll pass them along to Shannan or to whoever is appropriate. If the questions about previous sessions as well, I'm also happy to take those. And then just as a reminder, this is a monthly series and it's still ongoing, but we're not going to have a session in July. We're taking a little break for the summer. I think we'll be back in September. Is that correct, Misha? Or
We'll see who we get if anybody wants to speak during peak summer vacation season. But yes, thank you for that reminder, Francesco, that in July, it's just a little too close to a few holidays. So we'll take a pause and we appreciate you taking that pause with us and regrouping later on.
Yeah, so if you follow us on social media, you'll see when the next session is up. But for all of you who are already registered, you'll still get the reminder once those sessions are finalized. So yeah, Pamela, exactly. July 2nd is not happening. We'll be back August or September, depending on how it goes. So just stay tuned. Yeah, thank you so much to everybody. I hope everybody has a great day. It's a wonderful session.